Good morning everybody, and welcome to this introductory webinar, which today we're going to be covering the vestibular evoked myogenic potential, and in particular one of those potentials, which is the cervical vestibular evoked myogenic potential. My name's Lee Martin, and my role in Introacoustics is that I am the manager of the Introacoustics Academy. And at the Academy, we are responsible for providing training and education regarding new technologies and clinical practices in audiology. And we do that either face-to-face or through different media, such as this webinar. And I encourage you, if you haven't already, to have a look at our website at introacoustics.com/academy. But let's focus on what we're going to be covering today with the VEMP talk. So what I want to do really is to cover four core areas. I firstly want to introduce you to the cVEMP and explain where it comes from and its origins. After that, what I want to do is to actually guide you through the measurement steps and the things you should consider in order to get the best possible measurements when doing these tests. After that, what I want to do is to show you how to analyze a VEMP recording and what are the parameters which we should look at and measure. And then lastly, we can then go into the interpretation and look at what we'd expect the VEMP to look like in different conditions which affect the vestibular system. If we break the idea of the vestibular evoked myogenic potential down into its individual components, then the name is actually very self-explanatory, and we can actually get a lot of information from it. So if we start with the vestibular word, so the V in VEMP, vestibular, this is meaning, of course, that it's arising from the vestibular system, and we'll learn a little bit later that the main organs there which it's arising from is the saccule. Of course, there are two types of VEMP, and if we record from the eye, which is the ocular VEMP, then of course we're looking at the utricle. Then the next word for the E is evoked, and of course what evoked means is that we're going to be actually stimulating the vestibular system to do something. So what you can see on the image here is that I have a bone conductor and also some insert headphones. So we can actually evoke the vestibular system through an auditory stimulus. You can also use electrical stimulus also, but the most common clinical practice is to use an auditory stimulus. So the next word in VEMP for the M is myogenic. So myogenic really just means muscles, and of course what we can see now on the image is that we have a muscle of the neck, which we're going to be focusing on today for the cervical VEMP. And P stands for potential. So what we're looking is for a change in electrical activity from this muscle. So really, when you break the word down, the vestibular system is going to be stimulated, and that's going to cause a change in the muscle activity, and that's what we're recording with the vestibular evoked myogenic potential, and that's why we need to use a evoked potentials platform such as the Eclipse to get accurate recordings. So if we actually record this cVEMP, what it looks like on the screen is something that looks a little bit like this. What we have is a P1N1 complex, which is the vestibular component of the cVEMP, and then we also then have a auditory component from the cochlea, the N34 and the P44, but we're not going to be talking about the auditory component today, and we're just going to be looking at the vestibular component, and hence the reason why I've blocked that off and coloured that in. So if we go back in time and look at how these vestibular evoked myogenic potentials were first discovered, well, if they were really first described in the literature back in the 1960s, and Dr. Cody was the first to sort of make these measurements, and what they described is in their papers was a sound evoked muscle response. So what they thought is that when a sound of a sufficient intensity entered the ear, what it did is it of course changed some activity in muscles, and the original thought process there was that this arose from the auditory system being stimulated and not the vestibular system. But in 1964, Bickford continued to look at these recordings and actually found that the responses were recordable in those with hearing loss. So if that means that it couldn't really be originating from the cochlea, but actually then they also found that the responses weren't recordable in those with vestibular dysfunction. So the focus then shifted to actually think, this is a vestibular response, not an auditory one. And then it took another 30 years really for the research to actually identify what was actually happening, and McHugh actually looked at this and found that there are particular neurons in the vestibular system. He was looking particularly at cats, and these are called irregular neurons, and these are activated by low frequency acoustic stimulation. So actually the vestibular system does respond to sound, and this is how we're generating these VEMPs. So of course they're all non-clinical work, and really the clinical side really began shortly after or around that time, with Colbatch being the first to record these muscle potentials from the neck. And subsequently, of course, this was called the cervical VEMP, and of course is our main focus today. But also a few years on, Todd actually described a second form of VEMP, which of course is looking at muscles from the eye, known as the ocular VEMP. So you might ask the question, why are we having two vestibular evoked myogenic potentials? Why don't we just use one? And the answer there is because we're actually testing two different portions of the vestibular system. It's general consensus now that the VEMP test is a test of the otolith organs, such as the utricle and saccule, which are responsible for linear accelerations of the head. And what we can see in this image here is that we have saccule, which sits on the wall of the vestibular apparatus, and also the utricle, which sits on the floor. And the idea is that if you record from the muscles of the eye, then actually what we're doing is we're mainly picking up on projections from the utricle, and therefore we can see that the oVEMP is a test of utricular function, whereas the cVEMP, what we're doing is we're picking up mainly on projections from the saccule going down to the sternocleidomastoid muscle on the neck, and therefore this is seen as a test of saccule function. So actually with the two different techniques, although they're very similar, we can actually record two different areas of the vestibular system. We're not talking about the oVEMP today, and we'll focus on the cVEMP. So let's look at the cVEMP pathway in a little bit more detail. What exactly is happening? Well, when we're producing that loud sound into the cochlea, then what we see is that the saccule is being stimulated, and that is going to send projections down the inferior vestibular nerve and then to the vestibular nucleus. From the vestibular nucleus, what it's going to do is it's going to then travel down the vestibular spinal tracts all the way down to the sternocleidomastoid muscle. And remember, we said that the VEMP is going to cause a change in that muscle, and what we see with the cVEMP is that it actually causes an inhibition of the sternocleidomastoid muscle. So what we can say is that the cVEMP is ipsilateral, uncrossed, and inhibitory in nature. So what does that exactly mean? Well, first of all, cVEMP is ipsilateral, meaning that if we stimulate sound in the right ear, then we need to record from the right sternocleidomastoid muscle. Uncrossed means that the projections aren't going across to the left sternocleidomastoid muscle. And of course, inhibitory means that the muscle is going to inhibit, and that's what we're going to be recording, and that's the response of the muscle to that sound. There have been a lot of studies on the actual origin of the cVEMP, and we're pretty confident that the saccule is the source of the cVEMP. And the reason why is that what the studies have been shown is that you can actually record cVEMPs in patients which have complete destruction of the semicircular canals, as well as in patients which have deformed cochleas but normal saccules. Furthermore, there's also been proven that if you can surgically destroy the saccule, then the cVEMP will be absent, so giving us a pretty robust indicator that the saccule is the main mechanism. And lastly is that the saccule is associated with strong projections to the sternocleidomastoid muscle, again reinforcing that the saccule is the main generator for this response. So then we could ask the question, well, why look at the saccule? Is it actually important to look at when we're doing vestibular assessments? And the answer to that question, of course, is yes, it's very important. It actually comprises of 1/5 of the vestibular system. We have the 3 semicircular canals, which we can see here, here, and here. We have the utricle, which is placed here, and the saccule here. So all 5 portions are contributing to our balance system. And of course, if we're not going to test one area, then we are going to be perhaps in some patients overlooking where the root cause of the dizziness or imbalance. The other important thing is that the cVEMP actually supplies the inferior vestibular nerve. What I've done here is I've drawn a vestibular nerve, or an inferior vestibular nerve, connecting to the vestibular apparatus here, and we can see that this is the inferior nerve, and it projects and connects to the saccule and also the posterior semicircular canal. And it's important to know that looking for this particular disorder on the vestibular nerve, we need to be able to really locate the site of lesion to, is it on the superior vestibular nerve or is it on the inferior vestibular nerve? And the cVEMP therefore allows us a very nice test to actually to detect that. And lastly, we can say that the cVEMP is really the only test that we have available in our battery of tests to look at the function of the saccule. And that's different, of course, to, like, for instance, the horizontal semicircular canal, where we have the caloric test, we have the V-hit test, we have the rotational chair tests. So when we're looking at the saccule, we really are quite reliant on the cVEMP as our main test. Hopefully now we sort of have a little bit of understanding of where the cVEMP come from and what it's stimulating and its pathway. And what we need to do, of course, is now to consider the steps which are required for recording a cVEMP. And what I want to do is I want to cover 4 areas. The first will be patient preparation, the second will be recording parameters, the third will be patient instructions, and the fourth will be the recording and the analysis. So firstly, if we have a look at patient preparation, then what we can say is that what we want to do is we are using an evoked potentials device, and therefore we need to then place electrodes onto the person's skin in order to record these muscle potentials. So what we have is over 2-channel electrode system. Then what we can do is we can use the following electrode montage for our patient. So with the active electrode, what we're going to do is we're going to place that on the clavicular joint, and that is placed just down here. So if you feel on your next, your collarbone, if you come a little bit further up from your collarbone, there's a soft, fleshy sort of recess above that collarbone, and that's the clavicular joint, and that's where we want to put the active electrode. Next, we need to then reference that active electrode to 2 reference electrodes, and then we're going to put those on the sternocleidomastoid muscles of each side of the neck. So what we can see here is we have the sternocleidomastoid muscle, and what you can see is that it's in its shape. You can see that it's thinner at the top and the bottom and thicker in the middle. And what you want to do is you want to actually place that electrode on the thick body of the sternocleidomastoid muscle, so the thickest portion, and therefore you're going to be able to pick up that muscle potential much easier. The other thing that you want to do is that you want to make sure that the electrodes between the right and the left hand side are placed at the same level. So what you don't want to do is have one electrode which is very high up on the neck, close to the head, and on the other side have one electrode very low down on the neck, sort of closer to the shoulder, because then you'll get asymmetries in your VEMP recording which are down to electrode placement and not down to a problem in the saccule or the associated pathway. So electrode placement is quite important. Lastly, we have a ground, and the ground can really go in any position. Most people choose to place on the low forehead or the cheek. Once we have the electrodes on the skin, what we need to do is we need to ensure that the impedances are sufficiently low, and what we recommend is really for impedances to be sort of less than 10 kilo ohms. So this is a little bit more there's a little bit more slack here with the cVEMP. With AVR, of course, we're looking for less than 5 and within 2 or 3 of each other, but because the cVEMP is such a large potential, and we'll see this later on, that we don't really need to have such low impedances, because we can still record it with higher levels of impedance. Of course, what you do want to do is to still clean the skin in the same way as you would do with ABR. So you want to use some new prep or some preparation gel to clean the sites of any oils or debris from the skin, really to improve that impedance. But once we have a good level of impedance, then we are pretty happy and set up with our patient. And then we can actually look into the system and see what we're going to be recording and how we're going to change the settings in the evoked potentials platform. So what I'm going to do here is, I mentioned earlier, of course, that one of the ways to evoke the vestibular evoked myogenic potential is to use an auditory stimulus. And what we're going to do here is look at some of the stimulus parameters which we should take into consideration when choosing our auditory stimulus to generate the VEMP. So first of all, what I want you to do is to have a look at this bottom graph. So the first thing we need to do is to decide on the frequency which we're going to use as our sound. And if you remember what the study back in 1992 showed us, was that the vestibular system responds to low frequency acoustic stimulation. If we look at this graph, what we can see is different frequencies, and this is the size of the cVEMP here. What you can see is that if you go from very low to about 500 Hertz, so 250 to 500 Hertz, we can see that the VEMP response increases, and then after 500 Hertz we see a decrease in the overall size of the VEMP response. What that tells us is that when we look at these different frequencies, that 500 Hertz is the frequency which is going to give us our best amplitude in the majority of patients, and therefore that should be our starting point when we're going to do a cVEMP recording. Okay, let's look at the next thing, intensity. So we know the frequency, but we then need to choose an intensity. So how loud are we going to place this sound into the ear? And what we're going to look at is if a cVEMP is going to be present or not. And what we can see is that if we use a low intensity sound, this is looking at air conduction sounds, not bone conduction sounds. And what we can see is that in the low intensity sounds, some people will produce a VEMP around about 75 dB HL, but not very many. And actually what will happen is, as you increase the sound up and up, then the likelihood that you're going to get a VEMP is higher. And if you think about that, that's because you're going to be applying more energy into the ear, and you're going to be able to therefore stimulate that sacculus better. So the louder the sound, of course, the better, but we need to take into consideration if the patient's sensitive to loud sounds, and bear that in mind when we're going to be doing the VEMP. One thing I didn't mention on the patient preparation, of course, is that because we see this increase in sound and the increase in energy, if there is a problem in the middle ear which is going to cause some of that energy to be lost, such as middle ear effusions, then what we'll find is that we're not going to be able to record VEMP responses in these patients. So it's really a good idea to do tympanometry and otoscopy before doing a VEMP, just to make sure that the middle ear system is working absolutely fine. Lastly, what we need to do, of course, is then choose a stimulus rate. So with evoked potentials, we're not using pure tones, we're normally using a tone burst. And what we can see is that actually a stimulus which has a low repetition rate actually provides with the best possible chances of recording a cVEMP, and therefore what we should do is we should use a rate which is certainly lower than 10, and most people choose 5 because the effects below 5 are very minimal, and therefore 5 is sufficiently quick enough to get more sweeps recorded, but also slow enough to get a good VEMP response. So this is what it looks like in the Eclipse evoked potential software, the recording parameters. As you can see, there's quite a lot to change. If I just delete some of these areas so we can focus just on the VEMPs. Here we can see we have the stimulus parameters, and as we saw on the last slide, we're looking for a low repetition 500 Hertz stimulus, and here we're using a default of 5.1 stimuli per second. You can actually choose between your insert earphone, super or headphone, or you can use a bone conduction or bone vibrator. And if you are going to do bone conduction VEMPs, then we recommend you use the B81 bone conductor, which is going to give you a much bigger chance of getting a cVEMP than the B71, because it can increase to much louder intensities. In terms of intensity, as we saw previously, we need that to be a loud sound, and we're going to focus on air conduction VEMPs today. So really above 90 dB NHL is going to be a good starting point for recording your VEMP. The VEMP itself is a very large deflection, so most of its energy is actually less than 200 Hertz. Just consider that when you're applying your filtering. We recommend a low pass filter of 750 Hertz and a high pass filter of 10 Hertz. In terms of stimuli, because it's such a large response, we don't have to record for thousands and thousands of sweeps. You can actually see this response very quickly when you're doing it. So 200 sweeps is normally sufficient in order to get a good cVEMP response. You can often see it much before, but 200 sweeps, it normally allows for the noise floor to reduce sufficiently. In terms of recording window, well, we saw that the VEMP, we're looking for a P1, N1 around about the 15 to the sort of 25 milliseconds range. So what you want to do is make sure that you're going to encapsulate that area, but also the later cochlear potential. So we recommend a recording window up to about 80 milliseconds. And then lastly are some actual very specific parameters which we can look at for VEMP, and we're going to talk about those in a little bit more detail, so I will leave those for the next slides. So we've looked at our patient preparation, we've got our evoked potentials platform ready to record, but what we need to do now is to actually give the patient some instructions. So why do we need to do that? Wow, as I mentioned at the beginning of the presentation, the VEMP is or the cVEMP is an inhibitory response. So that means that the muscle needs to be contracted in order for us to look to see the effects of inhibition. So what we can see is we have our patient here hooked up to the electrodes. And what we can actually do is use a technology known as an EMG monitor to actually provide the patient with feedback to let them know if they are stimulating or contracting their muscle sufficiently enough so that we can actually record a VEMP. And what you can do is the patient can look at this monitor, and what you see at the bottom of this monitor is this grey bar. And there's two black lines here, which this grey bar is actually going to be measuring EMG activity, so the muscle activity of the sternocleidomastoid muscle. And what we want to do is, in order to record a VEMP, we need to actually have the this EMG or the muscle contracted enough so that the muscle contraction will fall between these two black markers. So if we have our patient at rest and we record the EMG activity from the patient's neck, then what we can see is that there is some EMG activity at rest, but it's not very much, and certainly not enough in order for us to generate a vestibular evoked myogenic potential. So this is where we need to instruct our patient. So what we tell the patient to do is to actually look in the opposite direction of the ear which is being stimulated. So if the patient is being stimulated on the right ear, then what we ask them to do is to turn their head to the left. And what that will do is we can see that the EMG activity has increased when they've turned their head to the left. Sometimes this will be sufficient and you'll see it cross over into this area between the two black marks, but sometimes it isn't. And if you haven't still managed to get the patient to fully contract their muscle by turning their head, what you can ask them to do is to bend forward with flexion of about sort of 30 degrees, and what that will do is that will actually generate a further contraction of the muscle. And what we can see here is that in this position our patient is actually contracting their muscle sufficiently, and therefore we're in a position where we will be able to record a VEMP if there is a potential there. So patient instruction is very important, and the monitor is really useful for assisting patients with this task, so they know exactly how much they need to contract their muscle. If you don't have access to a second screen, or your screen is in a different room to your test patient, then what you can actually do is you can actually use a monitor tone rather than a visual monitor, which will play a sound into the ear rather than using a visual stimulus. But most people tend to prefer the visual monitor over the auditory tone, but very useful if in setups where that's not possible. So we are now in a really position to actually record a measurement. So what I'm going to do is I'm just going to play the video of a measurement being recorded. So here we go. So what we're doing is, in this example, we're choosing a stimulus of 100 dB, and we're going to start recording the VEMP on the left hand side. So the patient's turning to the right, and we can see that the patient is sufficiently contracting their muscle, because this muscle contraction is between the two green, the two black areas. And on the video, what we can see is very quickly we see a VEMP recording appearing from the window. Of course, what we want to do is we want to repeat that again to make sure that it's repeatable, as with all evoked potentials. And you notice that as soon as you start recording the response, you can see that it is very quickly on screen and very large, not like an ABR where we're always spending a long time actually recording it. So once we have two and we're happy that those are similar, then what we can do is then move over and then test the right hand side. So we can say this has changed to red now because we're on the right hand side, so the patient's looking to the left, contracting their muscles sufficiently. We see the VEMP, and what you want to do is you want to see this sort of pre-stimulus area. This shows us how much noise is in the recording, and there's a little bit of noise in this one. Ideally you would like it to be flat, like in this one, to tell us that there's the noise floor is sufficiently low. But we can see what we're getting with these recordings is actually a response which is looking very symmetrical. So what we can then do is, once the recording is complete, we can actually mark the waveforms. So what we can do is we're looking for this P1, N1 complex here, and we can do that. One idea you can also do is you can actually merge these waveforms together so that you're just marking up a single curve, which sometimes might improve the accuracy of your calculations in your analysis, which we'll look up a little bit later. But if you mark the two curves, then what you can do is you can actually then you can link the right and the left VEMPs, and then what you can do is you can compare the amplitudes in the software. But we'll look at that in a little bit more detail later. But this slide is really just to show you really how easy it is to record these measurements. Let's actually look at the analysis. So we've seen the patient and we've recorded the cVEMP from them, and we've marked the waveforms. So what are we actually going to be looking at when we have this waveform? Well, there's two real things which we're going to be looking at, the P1N1 complex. So what we can see is that this is normally a large amplitude response. If you look at an ABR amplitude, it's normally around about sort of 1 microvolts. We can see that the cVEMP is much larger, often between sort of 50 and 300 microvolts. So it's a very large response, and that's why it's so easy to record. And amplitude is one of the key things which we want to be looking at. But when we're choosing our diagnostic parameters, what we can see is that there is more than amplitude. I have amplitude as the first one, but perhaps which is more used than amplitude is the asymmetry ratio, which is second. We also can look at the VEMP threshold, which is the quietest sound which can be used to elicit the VEMP. We can also change the frequency of the VEMP, so recording at different frequencies, 500, 750, 1000, 1500 hertz, and see the effect. And then lastly, you can have a look at the latency. But the latency is a very poor indicator of function of the saccule with the VEMP. So it's probably our least useful parameter. But before we start looking at all those parameters, what we need to do is actually really know if the muscle contractions which we've recorded are actually equal on the left and the right hand side. So we had the patient monitor, which allowed us to see if the muscles contracted enough to generate a VEMP. But even with the patient monitor, you can sometimes still get differences between the contraction of the left and the right neck contractions. And this is an example of what happens if you contract your neck muscles differently. So this is a patient which has, you can see on the right side, a very large amplitude P1N1, and on the left a very small amplitude P1N1. And we said that one of the parameters is to look at the asymmetry between right and left sides. So in this scenario, you might think that this patient has an abnormal left side, but in fact they're a normal patient. And we need to therefore make sure that we are aware that muscle contractions can cause differences with our VEMP amplitudes. Wagenpoler and Korbach in 2005, they described that VEMP amplitudes actually scale in proportion to tonic EMG activity. So what that means is that VEMPs will be bigger if you have more contraction, and if you have less contraction, VEMPs will be smaller, and we can see that on the graph below. And what they suggest is that after we've recorded the VEMP, what we need to do is to normalize the recordings to the level of the EMG activity. So how do we do that, and what does that mean? So if we have a look here, this is maybe an example of what happened during the test. What we can see on the patient monitor is that on the right hand side we have the VEMP being recorded, and it was recorded with the neck fully contracted with EMG bar all the way to the upper boundary of the patient monitor. Whereas on the left, what we can see is that the muscle was not very contracted and only really just entering the area for where we deem it appropriate to generate a VEMP response. So this is really the asymmetry which we're seeing in these recordings. So what we need to do is we need to eliminate that ongoing EMG activity, and the way that we do that is to use a technique called EMG scaling. So what EMG scaling does is it quite simply records before and after the stimulus. So what happens is when the neck is contracted, before the stimulus is introduced, we're going to record the EMG activity, and then after the stimulus has been introduced, we're going to record the EMG activity and also the VEMP response. And what you can do is you can apply this formula, so you can look at the averaged VEMP response over the root mean square of the pre-stimulation EMG activity. And what that will do is that will take away these asymmetries in EMG activity and therefore give you two VEMPs which are comparable. So what you can do in the software is just right click and press turn on EMG scaling, and when you turn EMG scaling on, what you can see is that in this patient you can see that the left amplitude actually increases, and now they look very comparable between right and left, and this has only been solved by the EMG scaling. In the software, what you can see above your test result is a graph that looks like this. It's called the EMG graph, and what we can see in this example is that the left side, this is showing time along the bottom and EMG activity throughout the test. And what we can see is that the left had a low level of EMG activity, sort of 90 microvolts, and the right had a very high level of EMG activity, around about 300 microvolts. And we can see therefore that these need to be taken into consideration. If you saw the right red line overlaid the left blue line, so they were both at the bottom, both looking very similar, then you wouldn't really need to switch EMG on, or the difference by turning it on would be very small. So what we need to do is, now we have the EMG option, and we can switch that on and off during our analysis depending on what we want to look at. Let's look at those things which we need to measure. So the first thing which I suggest which you can have a look at is the latency. Now, of course, the latency is the least diagnostic parameter, so it's not going to give you huge amounts of information, but it will allow you to identify the P1 and the N1. So the P1 typically occurs around about 16 milliseconds when using a tone burst. It used to be called a P13 back in old literature, and that was using a click stimulus. Really try and stress that it should be called a P1 rather than a P13 because the latency will change depending on the stimulus, and there are sort of boundaries for the upper limit of this. The N1 latency again also is associated with a sort of a latency of around about 25, and upper limit is 29. But this N1 latency is very variable, so if you the P1 latency is much more robust than the N1 latency. But again, as I mentioned, there's not really any diagnostic parameters which are looking at latency, and mainly amplitude and threshold effects and frequency effects are much better. So let's look at amplitude. So what you can see is that the amplitude of VEMPs can really vary quite differently between 180 microvolts and plus or minus 120 microvolts. So really you can sort of go all the way up to very high on large VEMPs and have very small VEMPs in individuals. So the amplitude is quite variable. So unless the amplitude is very, very large or very, very small, then again it's not the easiest parameter to actually make comparisons. But of course, as I mentioned, if it is very large or it is very small, then that will give you an indication. With very, very small amplitudes indicating sort of a dysfunction probably along that VEMP pathway, and a very, very large amplitude suggesting that more sound is entering the ear, and we'll look at an example of that later on. The most robust way of looking at the VEMPs is actually to make comparisons between the left and right. Because amplitude varies so significantly between individuals, it's much better to actually look at the amplitude asymmetry between the two ears. The amplitude asymmetry calculation is what we do is we record the largest amplitude and subtract that from the smaller amplitude, and then we add the right and left amplitudes and then divide the response. And then what that's going to do is it's going to give us a percentage, and that percentage is going to provide us with an indication of whether or not they're significantly different from each other. And studies typically sort of come in around this figure of around about 36%, some say 35, some say 33, but the figure which we use at Introacoustics is the 36% taken from the Young et al. Study. So if the VEMP asymmetry is larger than 36%, then we say that this is a abnormal VEMP, whereas if the asymmetry is less, then we say that that fits within the normal criteria. In addition to asymmetry of the amplitude, we can actually look at the quietest level which a VEMP can be recorded. And what we can see here is that we recorded at 100 dB, 95, 90, 85, 80, 75. And you can see that as the intensity reduces, then what we expect to see is that the VEMP becomes smaller and eventually vanishing at the quieter intensities. We'll look at an example of where that could cause a problem later on. But really, when you're looking for the threshold, you want to be looking for any asymmetry. So can one ear record to a much lower threshold than the other ear? And also you want to be looking at really how much lower than 80 dB NHL can we be recording, and anything very much lower, so sort of between 60 and 80, then you want to look at see whether or not there's sounds coming in through a different mechanism, particularly if there's an asymmetry. Lastly, what we can do is to actually look at frequency. So what we're doing with frequency is this is 500, 750, 1000 Hertz, 1500, 2000, 3000, 4000. And what you can see is that as the frequency increases from 500 Hertz, that the VEMP response gets smaller and then eventually vanishing. And again, we want to look at what frequency has the largest amplitude. We expect 500 Hertz to have the largest amplitude. Sometimes in older individuals that frequency shifts, but typically we're looking at 500 Hertz as expecting to have the largest. And what happens if that's not the case? Well, what we can do is we can actually look at some examples at these different parameters depending on sort of which vestibular pathology the patient has. When we talk about interpreting the VEMP, I guess from your patient history you would have an indication of which pathology you suspect them from having, and then you're going to be testing the VEMP to see if that pathology is actually confirmed by a diagnostic test. And therefore what you can do is that when you are doing your test, your VEMP test, then that would guide you on whether you're looking for asymmetries or thresholds or frequency tuning VEMPs. But the main way that we can use our VEMPs to actually help us is really looking at vestibular nerve disorders. We can use them in looking at superior semicircular canal dehiscence. We can look at them in patients with bilateral vestibular loss. And there's also newer applications looking at Meniere's disease. Of course, there are other applications such as saccular dysfunction and pre- and post-operative cochlear implants to see if there's any damage again to the saccule, but we'll focus on these four. So with vestibular nerve disorders, what we're looking for here is that we said that the vestibular nerve is comprised of two branches, the inferior vestibular nerve, which we said connects to the saccule, and that's displayed at the bottom here. So the saccule and the posterior semicircular canal. And then we also have the superior vestibular nerve, which connects to the utricle and the anterior semicircular canal and the lateral semicircular canal. By looking at the cVEMP, we can actually look at the one nerve independently. And if you remember, I mentioned earlier that the oVEMP, the second VEMP, is a test of the utricle. Then what we can see is that connects to a different nerve, to the cVEMP. So if you do cVEMP and oVEMP, you can actually get a lot of information. In a patient with a problem affecting the superior vestibular nerve, which we can see highlighted with these flashing dots, then what we'd expect to see is that the cVEMP will be normal in these patients because the cVEMP is going from the saccule to the inferior vestibular nerve, but the oVEMP, which is a test of the utricle and the superior vestibular nerve, will be absent or abnormal. Whereas the opposite happens if we have a pathology on the inferior vestibular nerve. What we'll see here, of course, is that the inferior vestibular nerve connects directly to the saccule, so our cVEMP will be absent or abnormal, and oppositely our oVEMP will be present. So you can really use these two techniques to make differentiations on where the site of lesion lies, if it's on the inferior vestibular nerve or the superior vestibular nerve. Here's an example of a patient with superior semicircular canal dehiscence. If you're not familiar with the condition, then what it is we have the superior semicircular canal here, And what you can see is that normally this superior semicircular canal is sort of encased in a bone, and what can happen is that bone is very thin here and it can erode away, exposing the top of the canal, so that when we present a loud sound into the ear, what happens is the sound can actually come in through this third window, and that extra sound coming through is going to cause more stimulation of the utricle and the saccule, and that's going to cause us therefore to have an asymmetry in the VEMPs in terms of their amplitude. And what you can see here is an example where we can track the amplitude of the VEMP all the way down. So what we have is on the left hand side we can see this is an ear which doesn't have superior semicircular canal dehiscence, and we see an amplitude at 100, and then at 95 dB the amplitude is almost vanishes. So we can say that this is very typical of a normal person's VEMP response. But on the right hand side we can see that the amplitude is much bigger at 100 dB, and we can see that it tracks all the way down to around about 60 dB HL. So what that's telling us is that the VEMP is being found at a much lower intensity than what we expected, and therefore we must consider that more sound is entering the ear, and that the more sound is entering the ear through this third window, and then you would want to do a CT scan to confirm the presence of that dehiscence. Bilateral vestibular loss, well, that's very easy. If you think of the patient which has damage to the vestibular system, then on both sides we'd expect not just the horizontal semicircular canals or the semicircular canals in general to be damaged. We would also expect the otoliths to be damaged. And here's an example of a patient which has bilateral vestibular loss displaying no VEMP recordings on the left or the right at 100 dB NHL, suggesting that there is a problem on both sides. So you can isolate each side independently and look for patients with bilateral vestibular loss. The last one, which I want to just share with you quickly, is those with Meniere's disease. And a paper published by Sandu et al. In 2009 suggests that in Meniere's disease, when you change the frequency of the VEMP, then what these patients show are larger responses to higher frequency stimulation. So if you remember back in my original notes or the original slides on stimulus presentation, we said that the VEMP is largest in normal individuals or people with normal vestibular function at 500 Hz, and then reduces down as the frequency increases. What the Sandu group found was that as the frequency increases, we also get an increase in the VEMP amplitude, and with sort of maximal amplitude sort of falling between 750 and 1000 Hz. So what you can see is that these patients will have a larger amplitude with a higher frequency. So what would that look like in your VEMP recordings? Well, it might look like something like this. So this is a left VEMP. We have it at 500, 750, 1000, and we can see that the amplitude is biggest at 500 and reduces down. But on the right hand side, what we can see is that we have 500, it actually then gets bigger at 750 and even bigger at 1000 Hertz, and then starts to reduce after that. So what we can see is that the VEMP responses have shifted, and what we can see here is this large response being present at the 1000 Hertz, and this is indicating that perhaps this patient has some endolymphatic hydrops, and Meniere's could be the cause of their dizziness, or at least endolymphatic hydrops anyway. Again, more research is required on this, but and it's happening all the time at different sites across the world, so hopefully this will be a very promising application for cVEMP testing in the future. What you can do is you can combine the cVEMP not just with the C and the oVEMP, but you can also look at the caloric test, the cVEMP and the oVEMP, and what you can see is you can actually isolate different areas of the vestibular organs. So you can actually really pinpoint those structures in the vestibular system and really have a clear idea of where the site of lesion is. And the same can be done with other techniques such as the video head impulse test, and you can see that you can isolate each individual end organ or nerve looking with these techniques. So we're in a really nice position now with VEMP testing, and also complementing it with a full test battery, as we can really identify where the problem lies. So I know I've run over by a few minutes, but I just want to say thank you very much for listening to my presentation on the cVEMP, and if you do have any questions, then I'm more than happy to answer them. Just type them in the message box below. Okay, great. So Bronwyn writes, very informative, may have future questions as I go over this presentation. And that's a very a good point to mention there, because what you can see is you can see the email address at the end here, academy@introacoustics.com. If you can't think of any questions now, that's not a problem. You can send those questions over to us at academy@introacoustics.com, and we will try our best to answer them. Just two more people typing. Jasmine asks, can you explain again what an inhibitory response is? So what an inhibition of a muscle response is it means that the muscle is going to sort of relax. So what that means is that if you think of the head rested just looking forward, the muscles aren't contracted, they're just relaxed. So what that means is that when you're going to record a cVEMP, you're not going to be able to allow them to relax very much more than what state they're already in. So what we're going to do is to do the contraction of the head. So we're going to turn their head to the opposite side of the ear, which is being recorded. That's going to tense the muscle, so that then when we generate the cVEMP, the stimulus, what that's going to do is it's going to allow the muscle to relax, or in other words, inhibit. So hopefully that's made a little bit more sense for you, Jasmine. Okay, so we have one last question. Thanks for the presentation. I am currently a second year student at UQ, and I remember hearing that patient fatigue could be an issue with cVEMP testing. How would you address this if you need to take several approaches to testing? I.e. frequency and threshold? That's a very good question, and patient fatigue can cause a problem for us clinicians, especially if the patient's older. They aren't able to do the tests very well, or certainly not many times anyway. So there's several different ways to help you out there. The first thing to do is to actually consider during the patient history what you think the condition is. So for instance, if you think it's superior semicircular canal dehiscence, then you're going to be looking to do a VEMP threshold test. If you don't think it's superior semicircular canal dehiscence, then you don't really need to do a VEMP threshold test, and an asymmetry test would be good enough. So asymmetry is the easiest because you only need 2 recordings, left and right. And again, the same with Meniere's disease. If it's not Meniere's disease, then just look to do asymmetry, so you only need a couple of recordings. In terms of asking the patient to contract their muscle, there are several different techniques. So the technique I talked to you about in the presentation was to turn the head in the opposite direction of the ear which is being stimulated, and then if that's not sufficient, is to provide flexion, so to bend the head forward slightly. But what you can do is that some patients really struggle with that, and you can actually ask the patient to, if they make their hand into a fist, and they place that fist underneath their chin, and they take their second hand and they place that fist onto that hand, and they push down on their chin, then what that will do is also stimulate the muscle in an easier way. And I can perhaps explain that a little bit better by sending you an email with some images of that technique. But that is a nice way of dealing with patient fatigue. The problem with that method is that you actually contract both sternocleidomastoid muscles, and the effect of doing a bilateral contraction is sort of unknown. So we recommend to do unilateral, but if you can't do that and the patient is fatiguing, then there is a second technique. Great. Okay. Well, I think that concludes the questions. As I mentioned, we're more than happy to answer any more at the email address academy@interacoustics.com. So please do send any more over, and we will answer that. As I say, the webinar will be up at the beginning part of next week, and the next webinar will be on the 7th of June. So thank you very much for tuning in today, and I wish you a very happy day. It's very sunny here in Denmark, so hopefully it's nice where you are too. Okay, bye-bye.